A very good evening or a good afternoon to all of you, depending on which part of the globe you are joining us. I welcome you all to the seventh edition of TUGSS Endoscopy, seventh academic webinar. Today we are going to talk about polyps, colonic polyps, and for this we have invited esteemed speakers and panelists to discuss all the aspects of polyps with you, from ranging from detection of polyps, characterization, how to improve the polyp detection rate during the colonoscopies, how to characterize them, how to perform a safe polypectomy, and finally, the emerging role of AI in polyp detection. I hope you all enjoy today's talks, and this webinar will be very useful to all of you. As usual, we will have three talks today, followed by a Q&A session, which will be with the help with panelists. As always, we invite you all to post your queries or doubts during the in the chat box during the session, and we will put them forth with the panelists for you all. So now I would like to introduce our esteemed panelists for today's session. We have Dr. Iswara Murthy, who is MS FRCS, FMAS, FIGS, FLES. He is a surgeon who is trained. Sir has been the immediate past chairman of ASI Tamil Nadu chapter, and he is the president-elect of the IAGS for the upcoming year. Sir is presently the consultant surgeon and surgical gastroenterologist at Lotus Hospital, Erode. Next we have is Dr. Bhavneet Balla. Sir is the founder and chief coordinator of TUGSS Endoscopy. He has done FMAS, FIAGS, and various FALS courses. He is currently working since 2009 as head of department and senior consultant of laparoscopic and interventional GI endoscopist in a super specialty 200-bedded hospital in Mohali, Chandigarh. Our third esteemed panelist is Dr. Sheikh Aziz Chaudhry from Bangladesh. Sir is working as a general and laparoscopic surgeon in Sylhet and is dedicated his service to the people of Sylhet. He is currently working as a professor in the Department of Surgery in Jalalabad, Rajiv Rabia Medical College in Sylhet. And sir is one of the pioneers of endoscopy in his field, in his area. So we welcome you all, esteemed panelists, to be a part of this today's session. Our first speaker for the day is Dr. Nitin Jagtap. Sir is a gastroenterologist from Asian Institute of Gastroenterology, AIG, Hyderabad. He has done his MBBS from Solapur, and he has done his DNB Medical Gastroenterology from New Delhi. So his main areas of interest are bariatric, metabolic endoscopy, obesity surgeries, and he has received various abstract awards and travel grants with various publications to his credit. We now invite Dr. Nitin Jagtap sir to continue for his first talk on how to characterize polyps. Over to you, sir.
Thank you, Dr. Parth, and I thank Dr. Balla and other esteemed panelists for giving me this opportunity to talks about colonic polyp. And share my slides.
Yes, you can share your screen.
So, are my slides visible?
Yeah.
Okay, let's make it full screen.
Yes, sir.
So, I thank TUGSS Endoscopy for inviting us at this forum. And a task for me is about polyp detection and its characterization. So I divided this talk in few subheadings, which is why do we need to detect polyps, how we can improve its detection, what is Indian perspective, and how we can characterize the polyp. So as we all know, colorectal carcinoma is one of the most common malignancy, and it ranks up in first three deadly malignancies. Though the recent time the mortality of colorectal carcinoma has improved because of improved surgical techniques and outcomes, and the majority of these colorectal carcinomas follow the sequence what we know as adenoma carcinoma sequence, and early adenoma which slowly progresses to late adenoma and eventually develops into carcinoma, and this gives us a lots of window period where we can early detect and treat polyp at before development of advanced carcinoma, and that is what the most important thing is, that we can treat disease at most early stage with minimum morbidity. So this is the recent study published few months ago at NEGM, which have evaluated the effect of screening colonoscopy on colorectal cancer and related deaths. And this study has underlined that the number of colonoscopy required to prevent one colorectal cancer is around 450. And in this randomized trial, the risk of colorectal cancer at 10 years was lowered among participants who underwent screening colonoscopy rather than who underwent colonoscopy as and when required. That means after onset of symptoms. So this has clearly shown that colonoscopy works to prevent colorectal carcinoma. However, in tandem colonoscopy studies in the meta-analysis has been found that up to 22% miss rate for colonic polyps, and it reaches up to 26% for adenomas less than 5 mm in size. So this brings us to next question: how we can improve the polyp detection. So this definition will come again and again. It's called which is adenoma detection rate. It's nothing but the proportion of screening colonoscopy performed by an endoscopist that detect at least one histologically confirmed colorectal adenoma or carcinoma. And majority of guidelines recommend it should be more than 15% for female patient and more than 25% for male patient. But this has to be looked in perspective of baseline prevalence of colorectal carcinoma in the population. So there are various methods that has been described to improve colonic polyp detection. One is colonic withdrawal time, adequate preparation, use of antispasmodic, use of advanced endoscopic techniques, and participation of additional observer. The most important thing is colonoscopy withdrawal time, and this a landmark paper in NEGM in 90s had shown if the colon withdrawal time is less than 6 versus more than 6 minutes, had shown that there is an increased detection of adenomas, increased detection of adenoma per patients. Also, there is increased detection of advanced neoplasia. However, the cancer per subject screen was not significant, and also the non-adenoma polyps detection was also more if we do prolonged withdrawal time for more than 6 minutes. Second part is adequate bowel preparation. This is the most commonly used score, which is called Boston bowel preparation score, which grades from inadequate, that is solid stool covering almost all mucosa, a stool that is covering majority of mucosa, and the liquid stool and completely clear mucosa, and it has to be graded from 0 to 3. And the adequate preparation is defined as the score of more than 6, with each segment having more than 2 score, and should be achieved in more than 90% of screening and surveillance colonoscopy. And majority of guidelines recommend preferably a split dosing, which is half dose evening prior to the planned colonoscopy and half dose 4 to 6 hours before colonoscopy. Second part is use of high definition colonoscopies for improvement of colonic adenoma. And this meta-analysis and systemic review of all randomized studies published had shown use of high definition white light endoscopy has improved adenoma detection rate as well as increased rate of advanced adenoma rates. Coming to third part, which is cecal intubation rate. The cecal intubation rate should be more than 90%, and the cecal landmarks such as appendicular orifice and IC wall should be photo documented in colonoscopy report. The most common mistake done by many of colonoscopists is they just peep through the hepatic flexure to the towards the cecum and don't go to the cecum. And the reaching up to the cecum is more important rather than just looking towards the cecum from hepatic flexure. There is high chance of miss colorectal polyps and colorectal carcinoma in right colon. So it's always preferable to have a second look. Either you go by forward view, or you can retroflex your colonoscope in cecum. And it has shown to improve adenoma detection rate by 5 to 20%. So next, what can be done at individual level? One should start documenting his own adenoma detection rate, and he should try for better results each time. There are few further technical systems which are available, but the availability is the main issue, which is such as with Olympus, it is having wide angle field of view up to 170 degree, Fuse, which is having 330 degree of view, and retro view, which is with Pentax, which is having short turning radius around, which allows retroflex withdrawal. There are few other technical devices which can be fit at the end of the colonoscope, such as this cap, endo cuff, endo rings, or eye balloon, and third eye panoramic device. However, as I already mentioned, the availability of this into the your unit can be a limiting factor, but this has shown to improve adenoma detection rates. So my colleague Anirudhaa has done this very study in large number of patients, around 10,000 patients, to understand what is the rate of colonic polyps and adenocarcinomas in Indian population. So for this study, we enroll around 10,000 of patients, and those who are having high risk for colonic adenomas, such as previously known CRC or family history and IBD, were excluded. In these overall population, there is 11.2% at least one adenoma, and 7.1% adenoma with advanced pathology. Adenoma in advanced pathology stands for size more than 1 centimeter, villus morphology, or high grade dysplasia. And for patients more than 50 years of age, this rate is up to 20%, and for adenoma of advanced pathology is around 15%. And these are the risk factors on multivariate analysis. What I want to emphasize is that for Indian population, increasing age, presence of metabolic syndrome, consumption of non-vegetarian diet, and alcohol were independent risk factors. As India don't have any screening program in place, these are the patient in whom we can consider opportunistic screening after age of 50 years. Coming to the second part, which is assessment of polyp or its characterization. So there are three steps. First is gross inspection. Second is pit pattern by chromoendoscopy and NBI. And there are other methods available with different types of scope. I won't be going into details of blue light and OCT and endocytoscopy. So the Paris classification, majority of guidelines mention that for each polyp, during reports, the gross morphological characteristics of polyp should be described with Paris classification system and size in mm. So they are divided any polyp into either polypoidal or non-polypoidal, and polypoidal can be subdivided into pedunculated if there is a peduncle, or sessile. In non-pedunculated, there can be slightly elevated, where the polyp lesion is above the surface of mucosa, flat, which is in the line, and slightly depressed, which is 2C, and those who are excavated are called as 3. The same I'm describing in the pictorial form, the 1P. Sometimes there can be overlap between sessile and pedunculated. It should be reported as 1SP. So this is flat elevation of mucosa. Flat elevation with central depression is 2A plus C. Then 2A plus 1S, which is having flat elevation with raised broad-based nodule. Flat submucosal change is 2A depression, and excavated is 3A. Coming to the second part, which is Kudo's pit pattern. So these are the normal pit patterns, which are normal round pits. If you see stellate-like pits, it's called as type 2. 3S is tubular or round pits that are smaller than the normal pits. So this required experience, and you need to see repeatedly so that you can differentiate between normal and 3S. 3L is tubular or round pit patterns which are larger than normal pits, which is 3L. Type 4 is dendritic or gyrus type of pits. 5I is irregularly arranged sizes of irregularly arrangement and size of different pits. And when there is a complete loss of or decrease of pits with amorphous structure is called as VN. In clinical practice, that leads to pattern 1 and 2, which is non-neoplastic. Pattern 3 onwards are neoplastic, and pattern 5, which is irregular decrease bit pattern, is neoplastic, but it's not resectable with, usually this indicate a deep submucosal involvement. NBI is nothing but extrapolation of the Raman effect, which stands for different depth of penetration for different wavelength of the light. So NBI works by filtering with white light into specific wavelengths that are absorbed by hemoglobin and penetrates only to the surface of human tissue, and it can enhance the visibility of vessels and other tissue on the mucosal surface, so that capillaries on the mucosa will be displayed at a brown, and veins in the mucosa are displayed as sign on the monitor. And NBI is based on this muscular and mucosal patterns, can be useful to predict the histological structure of the tissue. This is the same thing which is described. NBI uses red, green, blue filter to modify white light, and blue light filter highlights the capillaries in superficial mucosa through mean peak of observation of hemoglobin around 415 nanometer, and green light filters penetrate deeper into the mucosa. So depending on that, various classification are described, and the most commonly used is NICE and GENET, in which NICE has 3 subtypes, which is type 1, which is having a background color. The color of the polyp is same or lighter than the background. Also, the vessels, which can be none or either isolated lacy vessels which course across the lesion, and the surface pattern, which is either dark or white spot, which of uniform size and homogeneous absence of pattern. And these types of type 1 NICE classification polyps are usually hyperplastics. In type 2, they are browner relative to the background, brown vessels surrounding the white structure. There will be oval, tubular, or branch white structure surrounded by brown vessels, and these are usually neoplastic adenomatous polyps. When type 3 is brown to dark brown and relative to background, and sometimes patchy whitish area, there will be marked, distorted, or missing vessels, and there will be areas of distortion or absence of pattern. You can see the very well good pattern here, but you won't be able to recognize any pattern here, and that indicates deep submucosal invasive cancers. This classification is widely used in Japan, which divides like type 2 into two types, one type 2A and B, in which vessel pattern, surface pattern, and were described. The vessel patterns is usually invisible, and there will be regular dark white spot which are similar to the surrounding mucosa. These are usually hyperplastic and sessile serrated polyps. In type 2A, those are vessel pattern will be regular. The surface pattern will have a regular tubular or branched projections, which is usually a low-grade intramucosal neoplasm. This can be dealt with the endoscopic therapies. Type 2B is there will be variable calibers of vessel with irregular distribution, and the surface pattern will be irregular or obscure. This indicate high-grade or intra-submucosal neoplasia or shallow submucosal invasion. Whereas type 3, there will be very loose vessel areas with interruptions of thick vessels. You can see the thick vessels are interrupted in between. There will be amorphous areas in between, and that indicate deep submucosal invasion. And these patients should lead to surgical therapies. But the problem with GENET is it's not much validated outside Japan, and it requires a magnifying endoscope, and many of the centers won't have that magnifying endoscope. So one of my friend has studied this, whether this can be studied, GENET classification, whether it can be validated without a magnifying scope. And in this study, they have found that there is a reasonable good accuracy in characterizing colonic polyps using non-magnifying endoscopy in the single center at Bangalore. However, the sensitivity to detect type 2B is very low. So the assessment of deep submucosa remains challenged in if we use non-magnifying scope instead of magnifying scope for GNAT classification. So thank you very much. I will be happy to take any questions if there are.
Thank you, Dr. Nitin. That was a wonderful talk. Sorry I couldn't join you earlier. I had a technical glitch with my mic. It seems to have been sorted out. I hope my audio is clear now.
No problem.
Okay.
Yeah. Thank you, sir. So, I would like to now call upon our second speaker for the day. I would like to now introduce Dr. AHM Tawhidul Alam. Sir is a hepatobiliary surgeon in Dhaka. He is a qualified MBBS, FCPS, FRCS, and FACS USA. Sir is the chairman and professor in the Department of Surgery at Bangabandhu Sheikh Mujib Medical University Hospital, and he regularly provides treatments to his patients at Green Life Hospital, Dhaka. We would like to now call upon sir for his talk on colonic polypectomy tips and tricks. Over to you, sir.
So, Professor Tawhid, we lost your screen.
Yeah. Now you can see me.
Yeah.
Yeah.
Please go ahead.
Good afternoon, everybody. I am Professor Tawhidul Alam from Bangladesh. First of all, I would like to thank the Upper Gastrointestinal Surgical Society for inviting me to say something regarding the colonoscopy polypectomy, particularly in tips and tricks in related to the polypectomy. Basically, I'm a surgeon and doing full sorts of endoscopic intervention, starting from the all sorts of therapeutic endoscopy, RCP, US, everything. With this few words, I would like to start my presentation. As my previous speaker has cleared up everything, has mentioned about the risk of polyp in the adenomatous polyp in the cancer. So I'm not going in details. As you know, all you know, there is polypectomy reduces the chance of cancers, and the risk of polyp malignancy increases with the size of the polyp. Say, for example, a polyp greater than 2 centimeters has got chance of malignancy more than 10%. And actually, the method chosen for polypectomy depends upon its appearance and size. So, when the question comes regarding the polypectomy, you usually consider it's whether it is pedunculated, sessile, or flat. As my previous speaker has mentioned that about the Paris morphological classification, KUDOS classification, actually we consider all this classification when we want to remove a polyp, because this should be under consideration if we want to remove the polyp completely. So first, let's talk about the cold forceps polypectomy. Small polyp, 1 to 2 millimeter, that otherwise it is very true for snare polypectomy. So if we can remove it by snare polypectomy, definitely it has got some advantage. We are not using the electric energy, and definitely there is chance of perforation is very low. And disadvantage, as per literature, there is more than 10% chance of remaining some residual polyp by doing cold forceps polypectomy. Then comes snare polypectomy. Snare polypectomy, actually snare, there are different types of snares depending on its shape, depending on the nature of its wire, that is a parted wire or single wire. It may be rotatable, or it may be fixed, or it can be hot or cold. So snare may be different types of snare, and we use the snare depending on our requirement. Regarding hot forceps polypectomy, in one sentence, I want to finish this slide because we don't use this nowadays. It is not recommended. So let's come to the cold snare polypectomy. Small polyp, this small snare, that is 1 centimeter snare, you use for small this cold snare polypectomy also. Sometimes for flat lesion after piecemeal excision, for remaining case we use this cold snare polypectomy. Actually, this cold snare is nothing. We use a small snare for a small polyp. Difference is that we don't use any energy. But after polypectomy, there might be some bleeding, but it doesn't matter. It stops spontaneously. So for a small polyp, less than 5 mm, it is better to remove by small. This is the polyp we are removed from the cecum. So before going for a polypectomy, points should be checked. These are some points. Whether there is the instrument, regarding the instrument, whether it is this filling is smooth or not during its maneuver, and the snare wire thickness, because you can use the thin wire or thick wire. The problem with the thin wire, you can have a that is cheese wire cutting, that is cutting without coagulation. It can happen. So for depending on the situation, you can use the thin wire or thick wire. And another thing is squeezing pressure is very important. The pressure, if it is inadequate, that cut will be inadequate, or there will be bleeding is more. It is too tight, there is inadvertent early cut that can happen. So it is better to mark the snare handle with the pen for a large polyp, which helps to stop the closure of the snare. Because if you practice it outside the patient and mark the snare with a pen, and then you can regulate this control of open and closing of the snare. And definitely, when you are going for any polypectomy, it may be small, sessile, or pedunculated, you should have some armamentarium within your hand, like the injection needle. These are some accessories you should have in your hand. Dye spring cannula, but dye spring cannula nowadays you don't use, because most of the instrument now it is provided with the optical image enhancement, that is NBI and other image enhancement is there. So dye that is spray, there is chroma enhancement we don't use nowadays. And you should have clipping and lip device for any emergency situation. And definitely APC is a good option for hemostasis. And specialized equipments like hybrid knife, hook, and coagulus, these are also necessary if you want to do advanced polypectomy or for difficult polyp. And the specimen retrieval, for a specimen retrieval, you should have some other instruments. Snare itself can help in the removal of the instruments. Dormia, that is Dormia rod basket, suction trap, goes over the suction bottle. There is a certain device. And lastly, carbon dioxide insufficiency is essential, because during polypectomy you might take a long time. So because of, if you inflate with air, that causes discomfort after the procedure. So carbon dioxide insufficient, water jet, and definitely endocarditis that is mandatory for polypectomy. So a small polyp less than 10 mm, this is represent the appreciable majority of the polyp, and despite of their size, all polyps should be removed, and the polypectomy take day. So in summary, polypectomy for small polyp, forceps or cold snare, larger polyp, hot snare, and difficult polyp require special device and special techniques. Tips and tricks to make the resection and retrieval of a small polyps quick and seamless. As I mentioned, a small polyp sometimes it is very easy. Sometimes it becomes difficult to retrieve this small polyp. So you have to follow some tips. Say for example, tips 1, you have to examine the polyp both with white light and optical endoscopy. If the border of the lesion is not clear, and if the lesion is on the edge of the fold, then you should use submucosal injection. And third tips is that cold snare for a small polyp, and you can use the small that is cold snare for the large polyp more than 10 mm size, particularly for flat lesion. And definitely you need reorientation of the lesion at 5 o'clock position, that is 5 to 7. As you all know, that working channel, most of the colonoscope fiber is in the 5 o'clock position. So you should orientate your space, that is area of interest at 5 o'clock position. Ideal snare for cold polypectomy is a stiffer, thinner, and braided snare. This is monofilament. And tip 6. When you are going for a polypectomy, you just open the snare over the lesion, and just press the mucosa with the snare to flat it, and ensure to have at least 1 mm normal tissue around the base of the pedicle, that is around the polyp. And once the polyp is inside the snare, you apply single slide suction and then close the snare. This suction actually it thickens the colonic wall, and it reduces the chance of wall perforation. If there is too much tissue in the snare, definitely if you catch hold too much tissue at the pedicle, then slightly open the snare and reposition it. And tips 3, if you're unable to cut, sometimes it happens, and then retract the snare into the colonoscope, that is into the colonoscopy colonoscope, then it is the tag technique, and it helps in the cutting the base of the polyp. And removal is another challenge for the removal. You can use for a small polyp. Sometimes you might get lost to get the polyp. So you can use the suction to draw the polyps in. There's a suction trap, or you can if you sometimes you don't have the polyp, then you look for the resection site and suction the fluid in and around the suction site. If you still then you don't get the polyp, then you just wash with normal water and then suck again. In this way, you can retract the polyp. This is for a small polyp. And lastly, you should examine the polypectomy site for remaining polyp, and if needed, repeat course sinner can be used. And oozing, I have also mentioned, oozing not a problem. Now let's come to the difficult polyp. There is no standard definition which one is difficult, but depending on the size, morphology, site, and access, we can classify on the polyp which one will be difficult for polypectomy. Say for example, size and morphology greater than 2 cm in size, sessile polyp, and greater than 3 cm for pedunculated polyp, we call it difficult polyp. And site, particularly in the peridiverticular polyp, rectal polyp close to the dentate line, polyp over the ileocecal bulb, and appendicular opening, these are all difficult polyp. And polyp occupying the more than 1/3 of the lumen of the circumference, and polyp crossing the 2 hostal folds, and clamshell polyp, that is polyp wrapped around the fold. These are called difficult polyps. So for a beginner, you should consider which one is difficult, which one should attempt or not. And then steps of successful polypectomy: first you locate the polyp and you analyze the polyp shape and determine the polyp size, and at the surface by the pit pattern as the classification as my previous experiment nicely mentioned, and determine the number of polyp and estimate the resectability, whether you will be able to resect it or not, and use the submucosal cushion, that is injection. And definitely you should have all the skills. And regarding the location of the polyp, I have already mentioned which are the difficult location, and shape of the polyp, as you know, the peduncular to sessile. And size, we can 2 cm larger, we can very large, more than 4 cm, giant polyp more than 5 cm. But sometimes size is not important factor. Sometimes the important is the pedicle, whether it is short, long, or thick. So here you see that the surface, first the surface, you see that in the regular light, it is classical light, you see that is a polyp, but you cannot say whether it is benign or you cannot see in there. But on narrowband imaging, you see there is change in the pit pattern in the center, the whitish area. There is vascular marking is there. So this goes in favor of some neoplastic change over here, definitely. So synchronous lesion. Sometimes you will get the polyp, a patient having the carcinoma in the right column, having a synchronous polyp in the SNE also in the right column. So in this synchronous lesion, you don't have to remove this polyp, because this polyp will be ultimately removed by the same specimen during surgery. So sometimes if you get synchronous polyp and it is within the area of future resection, you should not remove it. And the number of polyp, in one session you can remove only not more than 10 polyp. You can, if you are expert enough, depending on the size, shape, and site, it is recommended you only first session you can remove the 10 polyp also. Essential steps in the resectability, as I have mentioned, the more than these are the site where you should stop. That is more than 1/3 of the circumference, covering the more than 2-fold and large sessile polyps. So these are the area not for the beginner. So planning. You should have the staff is very important. Those who are helping in, and you should have for equipments. And submucosal cushion. This is very important issue for polypectomy. That is polyp more than 15 mm. The flat lesion, saline epinephrine, indigo carmine. Usually epinephrine you don't use in the right column. It is we going to use. These are the usually saline and indigo carmine is more than I think it is enough. And after submucosal cushioning, usually small needle is used because it's tangential. It should be tangential, otherwise you can inject through and through outside the chronic wall. And for large polyp, proximal wall should be injected first, and after lifting. And sometimes this saline cushion injection helps in the tattooing also, future following up for the surgeon. And the position of the colon, this is a polyp in the rectum. As my previous speaker mentioned, that is retroflexion is sometimes essential before going for a particular resection. And for hot forceps polypectomy, the polyp, as I mentioned, that should be brought in 7 o'clock, 5 to 7 o'clock position, and the snare is deployed around the polyp. And sometimes you advance the snare proximal to the polyp. The polyp is proximal to the polyp is useful for the polyp if it is behind a fold. And the tip of the snare sheath is positioned at the polyp base as the snare is closed with suction in the ear, section of the ear. Once the polyp is grasped, it should be advanced from the scope tip and pulled away from the base of the lumen, avoid the contact. Because if your polyp is in contact with the other wall of the bowel, it may transmit electricity, or it may be if your polyp is in contact with the unprepared bowel, that is stool, it may cause local that is the electric dissemination. And close the snare slowly and gently to avoid the cheese wearing effect, as I have mentioned. And before cutting the base, a few seconds electrocautery is applied, then cut the polyp. Otherwise, there may be chance of bleeding. For a pedunculated polyp, snare should be placed about the half of the way of the stomach, because if you keep some of the stomach, then it will be easier for you to stop the bleeding or even clip application. This is simple pedunculated polyp, simple polypectomy without any submucosal elevation. Just apply the snare around the pedicle and apply the electric energy in the middle of the pedicle, and then apply the electric current, and you can cut it. So no need of submucosal elevation, nothing. Just this is a hot snare polypectomy. Most of the time we do it. Most of the polypectomy is done by this way, and you can remove the polyp with the same snare. This is snare polypectomy. The sessile polyp after submucosal injection, you can remove it by hot snare. This is the hot snare polypectomy for the difficult polyp. You see as a big polyp, or if you broad base peduncle, you can even see the peduncle. So there is a vascular, there is a visible vessel in the peduncle. So ideally, you should use a snare that is loop. You can apply loop in the pedicle, or you can go for applying the clip in the pedicle and then go for piecemeal action. Otherwise, this is so huge, you cannot hold in the inside a loop snare. So it is better to remove piecemeal, and then if there is bleeding, so I applied a loop at the base at the end of my procedure. So these are this is for difficult polyp. So endoscopic mucosal lesion, EMR, this is you can remove the entire lesion. It can be piecemeal excision of the polyp, and definitely you should start proximally. And for large polyp, you can go for epinephrine volume reduction. These are some procedure you know. So this is a sessile polyp, that is injection. After injecting, application of the snare and that cutting the polyp. It is endoscopic mucosal resection. And piecemeal resection, sometimes you can practice it. This is a case I did it for a recurrence polyp. This was benign in nature, and because of non-lifting, it was not possible to do ESD. So I choose the patient for piecemeal EMR. So ESD needed for en bloc resection and fibrotic lesion, recurrent lesion. It is very time consuming. Complication is more. So this is ESD for rectal lesion. Sessile lesion, you can see here, both the lesions are sessile, and so this is the technique. After injecting the base of the lesion, then you can go for circumferential incision to lift the to go for ESD. Sometimes we use the ESD EMR in combined. We call it hybrid ESD, where you use the technique of submucosal injection and incise the margin, and then we cut the polyp in with a snare. So in the right side, this is this lesion. This is during submucosal injection, and then we remove the lesion completely. So this is after the procedure, completing all of the lesion. So polyp retrieval, we can remove it through the scope, that is retrieval through the snare or basket, or with the suction. Then you can go for removal or fragment transmission on both the polyp can be retrieved or basket. This is the hybrid ESD. You can make a circumferential incision and then you can cut with the snare. This is hybrid ESD. So follow-up, there should be some follow-up protocol. Warning sign of where you should counsel your patient regarding the warning sign, particularly for perforation and bleeding. It may be early or late, and post-polypectomy syndrome the patient might develop. So this follow-up protocol is very essential. So take-home message from my presentation is that thorough assessment of the lesion is essential, and you should estimate your endoscopic resectability if you cannot from the start. If you do or don't start if you are not sure that you can remove the polyp completely, and hospitalize the patient if the patient is symptomatic, and definitely surveillance is required if you are any colonoscopic polypectomy after 3 to 6 months. Thank you everybody for patient sharing.
Thank you, Professor Tawhid. Indeed, a very interesting and a very comprehensive talk. I thoroughly enjoyed your demonstrations of ESDs, EMRs, and suicide polyp excision. So, Partha, can you please invite the last speaker for the day?
Sorry, I was not here. So I'm pleased to invite our third speaker for the day, Dr. Anirudhaa Pratap Singh. Sir is a consultant at AIG Hospital, Gachibowli, Hyderabad. He has expertise in small bowel and interventions, motility disorders, advanced endoscopic interventions like endoscopy, colonoscopy, enteroscopy, hepatobiliary disorders. And he has numerous original publications in international and national index journals, along with books chapters in national books. So kindly, I would like to now call upon Dr. Anirudh Singh for his presentation.
Thank you, Dr. Bhatt. May I share my screen, please?
Yeah.
So I'm not allowed.
Sorry, Dr. Balla, we'll have to make we'll have to add him as a co-host. Can you do that, sir?
Yeah, done.
Okay.
Please go ahead, Dr. Anirudh.
Okay. So now my slides are visible?
Yes, visible.
Yeah, thank you. So good afternoon at the outset. I thank TUGSS to invite me for this talk. So this topic is a bit overwhelming for physicians and surgeons. So I'm going to talk about AI in colonoscopy, but since we avoid what we tend not to understand, so the revolution is already here. So better be we have to be part of it. So just imagine this to be a colonoscope, and this is a physician, and we are standing on a lot of data and artificial intelligence. So we should not waste this evolution. So we will start with this slide. This was a landmark paper published in 2014, which showed that higher adenoma detection rate was associated with decreased risk of interval colorectal cancer. If you see that when we move from the quantile 1, which is adenoma detection rate of 7 to 19%, to quantile 5, which is 33 to 52%, which may be there with some experts, the number of interval cancers incidence decreased to an estimate of around 3 per 10,000 person year. So it is very important to have a good adenoma detection rate. So we are going to talk about some alien points. Actually, a lot of people are not aware of this. So what is artificial intelligence? It is an overarching term for algorithms and software which mimics human cognition for analysis, presentation, and comprehension of complex data through pattern recognition and behavior and creating their own logic. So to simplify this, it is just that a machine performing any task which a human can perform. And it is trained using extensive amounts of input data. And what is machine learning? It is a subset of artificial intelligence, including statistical techniques, which enables machines to improve at tasks with experience. Say, for example, you unlock your phone every day with your iPhone. So that is machine learning. What is deep learning? A part of broader family of machine learning methods based on artificial neural network, just like our brain synapses. So deep learning would be like Gmail putting your all spam emails into one folder, and once spammers become more smarter, the Gmail tend to learn that thing and prevents you from spamming from those mails. And what is deep network? Deep neural network is an artificial neural network with multiple layers between the input and the output layers. So if you see the left picture, is it a dog or a mop? So you may be easily identifying this, but if I put 1 lakh pictures in front of you and put one dog there, you won't be able to. So the other picture is Chihuahua or Muffin. So again, there are 10 pictures here. You will be easily identifying this, but this is how we train the computers to identify what is what. So if you go through the standard definitions, ADR is the most important, which is the number of screening colonoscopies in which at least one adenoma was found, divided by total number of screening colonoscopies into 100. Adenoma per colonoscopy is number of detected adenomas with total number of screening colonoscopies performed, and PDR is almost as same as it, but excluding the adenomas, all the polyps. So withdrawal time is more than equal to 6 minutes to achieve a reasonably well colonoscopy. So AI in colonoscopy is divided into 3 factors, that is CADX, which is computer-aided diagnosis, computer-aided detection, and CAQ is computer-aided quality assurance. Henceforth, I will be using short forms. So what is CAD-E? So right now, what you can use, there are a lot of commercial devices which are available, which is called as EndoBrain Eye, Endo8, GI Genius, CAD-Eye. I'm not going to go through all the names, but majority of them are the first 4. And computer-aided diagnosis, EndoBrain Olympus, EndoBrain Plus from Olympus are the pioneers in this technology, and CAD-Eye from Fujifilm. So what is CAD-E? What are the possibilities and scope of this computer-aided detection that minimizes probability of missing a polyp, thus increasing AD? It decreases the incidence of interval cancers and causes withdrawal times. What is CADX? It gives real-time diagnosis like an expert, and it causes reduction of insignificant polypectomies. It also helps in resect and discard strategies, like you need not send it to the pathologist. If you feel it is hyperplastic, you just resect and discard. It also aids in bowel preparation quality, maybe in future lesion size measurements also, and detection of submucosal invasion in real time. So it overcomes problems due to human visual perception, biases, fatigue, distraction, levels of stress, variation in training and expertise, and the endoscopist's personality also. So this is how Olympus Endo8 works. So you can see that a standard colonoscopy, a rectangular box is placed on top of the detected polyp. And while you're doing endoscopy, you might be fatigued, but to pick up such a small lesion is incredibly difficult without air. So, and there's a similar machine called as GI Genius from Medtronics. It picks up various lesions. You can see that these seem to be very small and insignificant on the observations, but since it is trained on a multiple millions of patients, it can track these lesions and give you an additional second observer comfort along with you. So if you see, this was the first study which showed that there was higher ADR in the CADI group as compared to the standard colonoscopy, which was 29% versus 20%. This was GI Genius, published by Hassan C in Gut. It was a CADI platform with high definition white light videos. It was FDA approved and it is scope agnostic. What does it mean? Scope agnostic means you need not have a separate instrument to attach to the scope. It is just like you have to attach an intelligence endoscopic module with the standard endoscope. Whatever company you are using, it will help you in diagnosing and detecting polyps with artificial intelligence. It had very high sensitivity with 99.7% with very less false positive rates. This was second aid study, which included 700 patients, which showed that there was 30% related increase in adenoma detection rate with use of GI Genius and 46% related increase in adenoma per colonoscopy rates. It was mostly beneficial for diminutive polyps, if you can see here. So this was 8-2 study recently published in 2022 in Gut, and actually saw the performance of non-experts with these devices. So ADR was significantly higher in the CADI group than in the control group, which is 53% versus 44%. And there was no difference in detection of non-neoplastic lesions. So we might as well say that experience played a minor role when you are with CADI. So this was a meta-analysis which was published, which saw and summarized all the randomized control trials. It also showed that there is an increasing trend towards detecting higher ADR with the use of CADI. So what is the sensitivity analysis? This was another meta-analysis which showed that ADR was higher with CADI as compared to a standard colonoscopy, that is 29%, more than 10% increase, which is actually achieved with intensive endoscopist training along with closed group, and it's shown to reduce colorectal cancers, increasing detection of non-advanced adenomas according to this meta-analysis. But advanced adenomas were similar in both the groups, and small polyps were detectable more than the large polyps. So we really don't know whether this is going to be helpful for larger polyps as well. So if you see ADR, if you consider this as the risk ratio of increasing adenoma detection rate, if your ADR is presently 25, it would be 37 with CADI devices. So this was the sub-analysis which showed that more than 10 millimeter also, and more than 10 millimeter and also diminutive polyps showed a increasing trend towards significance. So this was another device which was published in Gastroenterology in 2021. And this also marks it the green box, suspicious lesions. This also showed that advanced adenomas were detected as good as the standard colonoscopy, but adenomas had a higher trend towards diagnosis. So if you see, CAD-I detected more adenomas as compared to the standard colonoscopy. So this was a systematic review. So why we miss polyps? There are two reasons. One is the exposure error, that we are not able to expose the folds. And second is we are actually not able to see flatter lesions. So if you see network estimates of all these things, what contributes to missing polyps? So first thing is that if you expose the mucosa better, you would be able to see properly. So if you see computer-aided detection is very high confidence in evidence, chromoendoscopy and increased mucosal visualization. So I would suggest using a mucosal visualization devices like Endoscopy Vision from Olympus, along with the artificial intelligence to increase your adenoma detection rates. So this was the cost effectiveness. So all the time we discuss that what if we are diagnosing more polyps and resecting them? What if the cost increases? So in our developing countries, especially, we tend to talk about all these things. So there was a recent cost-effective analysis which showed that if we are considering that if we do more polypectomies, there is increase in cost. If we are avoiding cancer, there is decrease in cost. So what actually it is the estimate? So they did microsimulation modeling, which showed that actually the screening with AI, without AI, there is incremental reduction of colorectal cancer incidence by about 5%, and incremental reduction of mortality by about 3%, and reduction in cost about $57. So if you count in Indian or developing countries currency, it is quite high. So this was very surprising. So initially people thought that before this microsimulation modeling that AI will increase the cost as the equipments and all. But if you're trying to do that for the long term, probably AI saves you a lot of money. So this paper presumes 60% adherence to screening colonoscopy among individuals 50 to 100 years. So we move on to next thing, which is very important, which is computer-aided diagnosis, that is real-time assessment of and characterization of the polyps. So these are the various studies which have been published, which mostly include less than 100 patients, most of them. So this was the largest study. This is the Endobrain Plus, that is AI-assisted endocytoscopy. Why endocytoscopy? Because it is actually giving you a pathologic diagnosis in real time. You might not as well need pathologists in the future. So its diagnostic output is there in less than 0.3 seconds. So on the left side, what you see is a standard image. On the middle, what you see is stained image with a magnification endoscope that is around 60 to 80 times. And on the right side, you see more than 520 times magnified image. So magnifying endoscopy actually observes cellular changes from mucosal patterns and running of blood vessels, while endocytoscopy observes the shape change of the nucleus itself. So these were the characteristics which were done by Kudo et al. As Dr. Nitin had explained in narrowband imaging. So Kudo classified this into three primarily important things, and they developed this classification and validated also. So I will just summarize this, that EC1A and 1B are non-neoplastic lesions. It is similar kind of thing, but they actually make it simpler to be commonly available to all the people around. So that is not based on vascular pattern, it is based on the glandular pattern as well as the pit pattern. So EC2, EC3A is adenoma or the submucosal carcinoma, EC3B is SME or worse. So the good thing about is that you need not remember all these things like in NBI. So you just need to have a scope. And if I go through this, there is a typical image of the hyperplastic polyp. This is EC1B. It is showing small granules nuclei and a serrated lumen. So if you see this lumen, it is a serrated lumen. If you move on to next thing, it is EC2. Nuclei are swollen slightly and lumens are straight like this is adenoma. If you go through the invasive cancer image, the nuclei are swollen and distorted and lumens are unclear. And this was a attempt to characterize endocytoscopic vascular pattern based on the NBI characterization, so that if somebody doesn't stay or is not experienced, might as well as use this. So ECV1, V2, and V3, it is a similar kind of thing. So ECV1 is non-neoplastic, V2 is neoplasia, V3 is invasive cancer. So again, if you go through V3, this is a typical image of a hyperplastic polyp. This is regular pattern ECV2, that is a typical image of an adenoma, and this irregular corkscrew vessels is a ECV3. So this was another study, which these are the first study taking over 700 patients, which tried to actually see this how this machine worked. So they saw around 700 patients and multiple polyps, and they did AI analysis and feature extraction by texture analysis of these patients. So if you see here, rectosigmoid polyps, They have labeled it as CAD, NBI, that is through NBI endocytoscopy, and stained NBI. So what they use for staining, we also commonly use is the methylene blue 1% and crystal violet of 0.05% and make it to 10 ml, and we splash it over the polyp and then characterize it. So it had very high negative predictive value as seen here in this study, which was very important. And if you see here, the computer diagnosis among experts, non-experts, and also the endocytoscope, it was best with the endocytoscope. So this was again the validation thing which was done with the EndoBrain Plus, which sub-characterized these lesions. So this is how it worked. So in real time, this is a stained specimen of the polyp, which has been stained with crystal violet and methylene blue together. And it is AI-assisted endocytoscopy. It will give you diagnosis in real time. It will show it as invasive cancer in 99% probability. And if you take multiple readings, it will show it similar things. So at the bedside, you have diagnosed this patient with cancer, and you know you can't do polypectomy for this patient. This is very important. And so prediction of EndoBrain Plus for invasive cancers was very high. Almost in all of these patients, they predicted invasive cancer very accurately. So if you see on narrowband endocytoscopy, again, it was very high confidence with ECV CAT, that is endocytoscopy with computer detection of about 72%. With experts also, it was similar. And the probability of diagnosing it as an invasive cancer and sending the patient for appropriate management at right time was correctly identified. So what this was our study which we had published recently, and so we are showing this method that for a non-neoplastic polyp, we are first doing a white light examination followed by an NBI examination and characterizing it. And then what we did was we compared this thing with an endocytoscopy image with a narrowband imaging, and then stained it with methylene blue and crystal violet again, and saw the pit pattern. And endocytoscope gives a real-time diagnosis, as we can see, that non-neoplastic in 87%. For a neoplastic polyp, again, there is the same procedure. So what we are seeing is an NBI image, looks like adenomatous. So it is giving it as 99% neoplastic. So once we stain it, and again we characterize closely, so this is what you are seeing is 520 times zoom. And with methylene blue, actually you stain the cytoplasm with methylene blue, you stain the nucleus, and with the crystal violet, you stain the cytoplasm. So what we found was that if we compared the endoscopist who was blinded to the diagnosis of the endobrain and endobrain, whatever diagnosis they gave, so it had very high sensitivity and very high accuracy with a very almost 100% negative predictive value, which was very important to diagnose these invasive cancers and adenoma, and to be properly managed right on the table without actually consulting a pathologist. So this was a current study which showed very high sensitivity rates, and these were the established studies. So there was another project which was real-time differentiation of adenomatous and hyperplastic diminutive colorectal polyps during analysis. So what they did, they used deep convolutional neural network model, and they trained this artificial intelligence by the videos provided by TUGSS, which is an authority, who is an authority in colonoscopy, and they took all size ranges. And after doing this 223 polyp videos, they had validated in 40 videos. So this is again AI for GI. This is another device which is actually commercially not available right now. This also detects it in real time. So right on the table when you're doing colonoscopy, you click, at the click of a button, it says that it is nice type 1, nice type 2. So you do not have experienced endoscopists with you all the time to detect this. So this is nice type 1. And again, we are going to see a second example of nice type 2. So this is the NBI imaging. Once we go close, within 0.5 seconds gives you the diagnosis. So 125 polyps, of which 51 were hyperplastic, 74 were adenomas. It diagnosed almost 94% of the cases accurately, and it thus met the PV guidelines. What are PV guidelines? So these have been a landmark in a landmark paper by ASG, that is preservation and incorporation of valuable endoscopic innovations. So for any technology to come in, it has to have the sensitivity and accuracy of diagnosing an adenoma of over 90%. So this all endocytoscopy and all those technologies we are talking about met these criteria. So if we characterize these colorectal polyps based on the functional architecture, this was another paper which accurately diagnosed in 10 around over 1200 images, and they properly diagnosed the neoplastic polyp images along with hyperplastic images. So you can see that 96% sensitivity and specificity. This was another Chinese group which was published in Gastroenterology in 2017. And if you see, expert also performed as par with this, except the novice learners. So this was another paper. So real-time artificial intelligence based, and it also gave the diagnosis on table. This is not officially and commercially available right now, but this also had fairly high sensitivity. This was the recent paper comparing CADX with the standard method, and this is the first paper published in NEJM Evidence. It also showed higher sensitivity of diagnosing adenomas as compared to the standard colonoscopy of over 90% with CADX and 85% correct specific negatively it ruled out these polyps as adenomas and invasive cancers, and with a very high negative predictive value. So this was our recent paper published in Journal of Crohn's and Colitis. So this was a model basically. So there is a lot of subjectivity as in clinical validation and inter-observer variability when people are diagnosing ulcerative colitis and grading it. There is a lot which depends on its treatment and also prognosis of the patient. So it is very important to properly diagnose these patients and characterize them. So this deep learning model was to improve, accelerate, and automate UC detection and predict the Mayo endoscopic subscore and the ulcerative colitis endoscopic index of severity. So on the left side, there are a list of videos. This is a standard video. And on the right side, it's a scoring system. Once you start to review it, actually this automatically convolution networks diagnose and characterize it along with the disease severity. So what you're seeing here is black box is actually ungradable. That is poor preparation or poor visualization. Turquoise color, what we are seeing here is where people have taken biopsies on the table so that you can correlate with the pathologic reporting. And the green, red, and yellow describes varying severity of this UCAS and Mayo endoscopic subscore. So we have developed this model recently, and this helps in grading. And this is an experimental study. It will go further as to how to grade these patients for biologics and all, and how to follow up these patients when you are diagnosing certain severity on colonoscope. So what are the limitations? So ImageNet is not available. So like a DNA project, Human Genome Project, they made it available all throughout that, the standard things were available. So we have to make an ImageNet, which will include all the endoscopic images across the world, start collecting data and see. And images do not equate to video. So we have to collect, record more videos, train artificial intelligence on videos, because dynamic thing is videos, not images. So most of the time it should be able to diagnose in real time. And there is a changing technology. So whatever pixel densities we are using right now, it has changed a lot in last 10 years, and it will change more in next 20 years. So we have to be very careful in training these equipments. And there is generative adversarial networks. What does it mean? That actually we have to train two systems to mimic each other. So one becomes better, the other copies it and becomes better. Simultaneously, we have to train 2 or 3 systems. And screening colonoscopy, till now there is no data, but however there are 4 or 5 RCTs which have been registered. And follow-up colonoscopy after FIT positive also, there is sub-analysis data which is available, which increased ADR from 48 to 60% in group of 200 patients by REPICI in gut in 8-2 study, but it is still not validated. Future challenges would be big data and deep learning. Also, what about the medico-legal aspect? And what about representing wider population? Since most of these studies have been performed in the West, so we need good global clinical trials and also look for insurance coverages for these devices. So my talk will conclude with this. So will AI and doctors compete or complement each other? So with this image, I think that we will be able to complement each other. It will always act as a second observer, and patients will always need our helping hand to make their diagnosis and explain them the prognosis. So finally, I end with this slide. So it is the pilot, not the plane for me. So we will always be important. Thank you.
Thank you, Dr. Anirudhaa. Indeed, a very exciting talk and a lot of new things which we have seen and expect to see in the future also. So the forum is now open to Q&A session, and I would invite the experts if they have any comments before we start taking all the questions. Okay, so may I just go with the query? This is for Dr. Nitin. This is for you. I wanted to ask you, what about the sessile serrated polyps? Where do they fit in these classifications, and what is their significance?
So as personally, I don't have any experience, but regarding sessile serrated polyps, but they are more common and more commonly missed in right colon, and in basically it's a histological diagnosis. So you need to train your eyes for that. And then you take biopsy and follow.
Yeah. So taking this question over to Dr. Anirudhaa. So is AI somehow helpful for us in picking up this sessile serrated polyps, which all of a sudden seem to be getting lot of mileage and importance
Yes,
as far as
so the
polypectomy
same
is
thing.
concerned?
So, in Indian population, whatever data also we had analyzed, Dr. Nitin showed that data of 10,000 patients, which is going to come up. That may be the single largest study from India. But the problem is that we don't find serrated polyps enough to characterize them. But still, AI would definitely be helpful, and there is existing data that CAD-E actually detects more serrated lesions as compared to the that is its utility is more in flatter lesions as compared to the elevated lesions. So data is coming up for the size of more than 1 to 2 centimeter, and probably since it is a self-learning, we expect it to be better in future. So it definitely helps.
Great, thank you. And this was a very interesting information which I actually gathered from Dr. Nitin's talk about the incidence of adenomas being about 15 to 20% in the Indian population. I mean, we generally have an impression that the Indian population or the diaspora usually have very low polyps in the colons. But this seems to be a very, very important figure coming out from this very important study, I must say.
Yes, sir. This was very like we were planning for this Indo-Brain and other AI related projects at our institute. But before that, we thought that it will be more useful if we see how much polyp we are actually there. So all these 10,000 polyps were 10,000 colonoscopy were meticulously performed with all the standard criteria to fulfill, like colon preparation, more than 90% cecal intubation rate, withdrawal time of more than 6 minutes. And then we could found that age more than 50 years, there is up to 20% adenoma prevalence. But still it's very low as compared to the Western population. But the previous studies which were done in 2090s, the incidence has picked up. It's almost doubled. Like the older study by Dr. Amrapurkar, he has reported incidence of 7 to 8% for adenomas, and in age more than 50 years, but now it's around 19 to 20%.
So, Professor Tawhidul, I would like to have your comments about this. Any idea about any study which is talking about the incidence in your country? What's the incidence of colonic polyps there?
Actually, the incidence is more or less same as the previous speaker has mentioned, more or less same. It corresponds with the Indian study also.
Right. And my next question.
There is one more point, sir. These are all diagnostic colonoscopies, though, and the what Western literature is reporting is screening colonoscopy. So all these patients had pain, PR bleeding, anemia, like they came for symptoms, and then we collected their data. So for screening, it may be still less, not it won't reach for 20%.
Right. Now, Professor Tawhid, I would like to your inputs on this. How would you manage the complication of a perforation after a polypectomy? You know, there are a lot of young surgeons who are planning to, or they have started doing colonoscopic procedures. So, how would you manage a complication if it happens during a complication? Obviously,
obviously,
is a major concern.
As you have mentioned, that regarding polypectomy, there is two complications. Number 3, I should go. There is post-polypectomy syndrome is not so serious. It is spontaneously resolves. But regarding the perforation and bleeding, these are the two complications. So as I have mentioned, the bleeding during cold snare polypectomy for small polyp, it is usually stops spontaneously. It does not require any intervention. But for larger polyp, particularly pedunculated polyp, not for sessile, pedunculated polyp, the chance of bleeding is more. So you have to, as I have shown, that you have to have some armamentarium to at least to control it, either by clipping or by loop ligation. And the perforation during intervention, I have not encountered any of complication, because I start whichever I can do within my limit I work. So perforation I have not encountered, but colonoscopy bleeding I encountered in one patient, and ultimately managed by subsequently by clipping. And yeah, one patient I can remember in early part of my experience, I used hot biopsy forceps. And hot biopsy forceps, after second day, this patient came with huge abdominal distension. It was in the sigmoid column. So that patient developed perforation because of this hot. I have mentioned I don't use the hot forceps since then, and literature also says that it is not safe. So for the beginner, one should not use hot for polypectomy forceps for removing a small polyp, because you also decrease the quality of the specimen. Also, it has got chance of perforation. So it's my advice to the beginner: don't use hot forceps, polypectomy forceps, and definitely chance of perforation. ESD there is chance of perforation, but if you are careful enough, and even after dissecting the area, you can use the close the defect by using clips. But nowadays I don't use clip. I just keep the particular rectum, keep the area open, and it usually spontaneous heals.
Thank you, Professor. So Dr. Roop Jyoti has raised his arm. Welcome, Dr. Roop Jyoti. You have a query.
Hello, good evening.
Good evening.
Nice presentation. My question is, I have hardly come over perforation. Sometimes there used to be bleed, but polypectomy, I have not encountered any sort of perforation. But during diagnostic, I had 2 perforations in my career. So I had to manage by surgery only. And it happened in the sigmoid only. And that too happened after my experience, almost about 15, 16 years of experience. After then only it happened. That was a diagnostic perforation. And my second question is red meat a fear factor for colonic polyps? Because while I was in Singapore, that time I have seen that they used to have more polyps, colonic polyps and colonic carcinomas. Whereas here in Northeast India, particularly in Assam, we get more cases of upper GI cancers. So what is your experience in Bangladesh?
Yeah, in Bangladesh, actually we get upper GI cancer, particularly carcinoma esophagus, stomach cancer, we get more than the colonic cancer carcinoma. This is also true for this part, maybe because of diet habit and everything as a factor working on this issue. Because we get carcinoma esophagus, particularly area for their definitely for their diet habit, and carcinoma stomach we also getting. But in relation to colonic cancer, definitely it is also less in our part, in this part of the world.
But we get more upper GI cancers than lower GIs, probably highest in the country, in India. Probably it has been reported in the ICMR studies.
So, Dr. Rujati, I am just a little bit interested. After 15, 16 years of experience, you had 2 perforations in the sigmoid during a diagnostic. Any specific reasons? What were the cases like, or what happened?
Maybe because of my overconfidence, that may be one of the factors. And it happened to one of my colleagues. He's a professor in the medical college, his father. Then immediately I call upon Dr. P.K. Chowbe, what to do. You don't worry, you just operate upon. You need not have to do any sort of colostomy because the bile is already prepared. So that way, first case was done. A second case was the patient was at that time we usually do without sedation. That was one of the factors. Patient was little bit was not allowing to do the colonoscopy, and maybe due to some that is my fault only. I had 2 perforations out of my 20,000 cases of more than 20,000 cases of colonoscopy. But I do more cases of upper GI endoscopy, and hardly till now I have not encountered any sort of problem perforation like that. Only I had in my career only 2 perforations, and that too after an experience of almost 16, 17 years almost. So now it's okay. I'm much careful about it. Maybe due to some overconfidence, I suppose.
Thank you, Dr. Ujjoti. I really appreciate that honest and candid reply. And this is actually a message for all the beginner surgeons who are planning to do all these procedures. One should always be, or rather, one is as good as his last procedure, I must say.
Yes.
Now,
Being a surgeon, it is not that difficult to manage, because once you commit a perforation, you see a laparoscopic view in colonoscopy. You are doing a colonoscopy and you are doing a laparoscopy. So that is about it.
I have one
Yes.
experience about during polypectomy. One of the gastroenterologist colleague in our institute, he did polypectomy before burning it full. So accidentally the polyp is removed and the pedicle is profusely bleeding. At that time, it is about 4 years back. At that time, we have no loop, no clip, etc. For that reason, he called me. I go there and look, and immediately take the patient in operation theater. Then I apply a gel bond platform under anesthesia transanally, and look there, introduce the laparoscope. Then I ligate it. The lesion is about 20 centimeter from the anal part, and the patient can see.
That is a very common part. Means the rectosigmoid junction is the commonest part, what I believe.
Yes.
Thank you.
So another query which I would like to be answered is, we have been talking about doing a polypectomy and ESGs and EMRs. But even before we decide to excise that polyp, we should always look for signs whether there is any submucosal invasion of this polyp or not. So, Professor Tawhid, how do you decide whether this is a resectable polyp, or this is beyond the submucosal and should not be?
Actually, I have already mentioned in my talk that whenever I go for polypectomy, I keep in mind in all the classification of polyp. That is the Kudus classification, that is Paris classification, with which classification they are staying. Then I go for polypectomy, and first attempt I inject submucosally to elevate it. If I think that there is loss of elevation, it is actually rather than elevating, it is depressing after injection, then I stop the procedure. This is my mostly I use the technique, because for pedunculated polyp it is not a problem. If you can manage the peduncle even after doing polypectomy, there is bleeding, because it is possible. Or prophylactically we use, even I have applied 2 clips in the pedicle to control the bleeding, to prophylactically before starting polypectomy. But for sessile polyp, when I see that there is it is not elevating properly, then I think twice whether I should proceed or not. For beginner, one should not proceed for polyp, sessile polyp, that which is not elevating, rather it is depressing. Depressing in a sense, comparative depression. Whereas you are injecting the surrounding the polyp, but it is gradually going downwards, but your injection is elevating the surrounding mucosa. This is my message to the beginner.
So the submucosal lift of the lesion is very, very important.
Very important. Before doing EMR.
So, any further queries or comments? I think we are almost approaching the end of our session, and a couple of minutes left. Dr. Pratap, would you like to, have you already posted the feedback format? Okay. So, a couple of things which I wanted to mention. We have already posted a feedback form for all the attendees. So we'd really appreciate if you can just take a couple of minutes out of your time and give us a feedback about this session. And this basically helps us to plan our further sessions and improve upon them in the future. And a certificate of participation will be mailed to all the attendees who have attended the session for a significant period of time. And for those who have still not joined, I would request all of you to join the TUGSS Endoscopy WhatsApp group, where we it's a common platform where we keep updating about all our future and upcoming TUGSS Endoscopy academic activities. So I guess that's it for the day. And I would like to thank all the speakers and the panelists for taking their time out on a Sunday evening and making this session a great success. I thoroughly enjoyed it and look forward to having all of you again in one of our future activities. Thank you so much, Professor Tawhid.
Thank you, Dr.
Thank you, Dr. Anirudhaa. Thank you, Dr. Nitin.
Thank you, sir. Thank you.